garbage can. Call it fibromyalgia if you didn't know what else to call it. And then it turned into this thing that was so specific there was maybe 5 doctors in all of Portland who could actually make the diagnosis. And so are we clear about how to really call fibromyalgia as opposed to a chronic pain syndrome, otherwise unspecified?
So this is the question of lumpers versus splitters, right? So we were being a splitter back in the 1990s when we said you had to have this specific kind of widespread pain and these requisite tender points that many people couldn't find, right? And so we went toward then this broader criteria, which was really patient self-report of a variety of signs and symptoms or symptoms. Since that time, we've been concerned about not sensitivity, but specificity of those tools. So now we have 3 more, and this year at the American College of Rheumatology, this newest one will be debated. So I think that right now what clinicians are doing is a combination of the 1990 and the 2011 criteria, but those are not the only way to diagnose. But I think importantly, what people need to think about is someone that comes in their office with a regional pain syndrome, just to understand there's a large body of literature that says most regional pain syndromes do not stay regional. They become more widespread. And to have only 1 or 2 areas of pain is really the anomaly, not the normal. But as clinicians, sometimes we think, oh, this patient has this one diagnosis, so that's what they're going to have forever. But really that's not what we're seeing either in clinical practice or now in neurobiology.
Thank you. Vern, do you have a question? No. Adrian, do you?
Hi, I guess I have a similar question related to diagnosis, because at least in the proposal for the line code, it's to include both fibromyalgia and then also like a chronic pain syndrome. And how do you delineate between those different conditions in terms of diagnosis?
Yeah, that's a good question, and it's one where clinicians are having to practice without an agreement from the scientific community about where we are on that. So for fibromyalgia, either the 2011 or the 1990 criteria is perfectly acceptable. Social Security, disability, third-party agents that look at disability accept those. But there are other proposals moving forward about body pain mannequins and how many areas need to be there and what's the best way to get a patient to endorse not just the most painful areas, but all the areas that are involved. So it's continuing to be a moving target.
And that was one of the things in the task force was the initial proposal was just to have chronic pain syndrome, but then their internal discussions were it's sometimes it overlaps a lot with fibromyalgia. So to not move that specific diagnosis, but to move chronic pain syndrome was difficult.
Okay. Yeah. In fact, there was a lot of that in the written testimony. Fibromyalgia was very prominently present in the written testimony we received, and so so it's imprecise. I can understand why they recommended we lump it. Any other questions? Okay, so we're ready to go to public comment.
Thank you guys for getting that.
Thank you. So what I've noticed in Daphne, are you gonna are we gonna call people up
next? While she's bringing up the rest of the names, I did want to go through those that were maybes on the initial list and see get a definitive answer. Carl Probst, would you like to testify?
I would.
Okay, thank you. Stephen Hicks.
Yes, sir.
That was a yes?
Yes, sir.
Okay. And Amanda, is it Seavey?
Yeah.
Okay. All right, so. Okay, so we've got 14 people signed up. So go ahead and do 2 minutes apiece.
I'll take mine off then.
Oh, I'm sorry.
You can check Julia off.
And so one of the things I've noticed is that just the act of transitioning between one to the next can take away time. So Daphne, if we could read the person who's coming up and the next person after, so the next person can get ready. It just makes it a little easier to get people in.
Or what about having two people come up?
We'll have two people at a time, so we can just kind of, yeah, I just wanna make sure we don't spend half the time just waiting, hearing as much as we can.
My name is Tim Arliss. I'm late on the list, but because of constriction of time, you may remove my name from the list.
Okay.
And there will be more meetings, so if you're not able to testify this time, we'll make sure.
There wasn't going to be.
Yeah, the
though,
only
correct?
reason there are gonna be more meetings is because you decided to put off that decision. So that's why we're all here.
Right, well, that was our goal, is to make sure we can hear the public.
Right, but that's why we wanna be heard, is because the decision was supposed to be made today, and so, we're here to make our voices heard, because this decision was going to be made today, and
I think if you actually listened or at previous meetings, that's never been the plan. This is as Dr. Smith was saying, this is a big potential change to the prioritized list. There's no reason to make a decision before March. It doesn't go into effect until January 2020, and so we knew that this was going to take multiple meetings to decide.
right, but you started out this meeting saying that you were delaying the decision that was gonna be made today, so.
Right.
I'm just raising my case.
That was just to let you know.
Yeah.
We were trying to
Thank you.
clarify that no decision was going to be made today. I don't think there was ever an expectation it was going to be made.
Okay, let's just keep going, we got our time.
Alright, so just to, give you all just kind of a flow, we will call up, two folks at a time, just to set the table. We ask that you state your name. If you are representing any group, please state that group. And then any conflicts of interest that you might have. Being a patient or a provider is not a conflict of interest, but if you receive, funding from any particular source or other conflicts that would be relevant.
And I apologize in advance for mispronunciations of names, so if I get it wrong, please correct me once you get up to the chair. Could I have Carolyn Concia and Bob Twillman? And again, after we hear your name and affiliation and conflicts of interest, I'll start the time, and then I'll give you the 60 seconds and 30 seconds of time indications. My phone is over there. Carolyn, if you'll start.
Okay, I'll look at it.
And if we can put our mics on standby, that would reduce our feedback.
Hello, good morning. My name is Carolyn Concia. Can everyone hear me okay?
Yes,
Yeah.
thank
Okay.
you.
I am a nurse practitioner in private practice in Portland. Sorry. All right. I have no financial disclosures. And I've been a nurse for 28 years, 18 of which has been as a nurse practitioner, serving medically complex patients, mostly seniors and disabled who are homebound. I've observed the following. Patients have been stabilized on their opiates for many years. They were doing well and living life as best they could until their providers started tapering their medicines, oftentimes without a discussion or without their consent. So this directly impacted the severity of their illness, and it destroyed their lives. They were productive members of society. They were taking care of their kids, their aging parents, and for whom they were trying to provide care. But most shocking, these patients had been turned away by providers in their own community. I personally have 2 patients suffering from intractable pain that were rejected by at least 10 providers in their own communities because of their pain. And my question was just, how is this not discrimination? It's my hope that providers not feel fear every time they see a patient who's suffering, and it's my hope to continue providing care for patients, offering a customized individual plan that is best suited for them. I understand that there are individuals who are suffering from addiction to a medical problems or an addiction unrelated to other medical problems. Dealing with this problem should not deprive chronic pain sufferers of medicine that's been proven safe and effective in keeping them as functional members of society. I don't think the answer lies in deprescribing or underprescribing according to artificial government limits, which ignore individuals' needs. I feel that patients who come to a provider
tapers in those patients. I understand that you're in the 20th month of a similar 12-month plan to forcibly taper patients with back and spine pain off their opioid pain relievers. Clearly, the policy is not a rousing success, but there appears to be a willingness to impose it on another large group of patients. I think any such decision should be delayed until you have a clear understanding of the reasons why this plan has failed in that population. Specifically, I believe that you should do a thorough evaluation of outcomes experienced by patients whose doses have been tapered. What happened to their healthcare utilization and levels of pain and function? What happened with respect to mental health diagnoses, overdoses involving illicitly obtained opioids, and suicides? All of these questions, and perhaps more, need to be answered before you risk bad outcomes associated with forced tapers in yet another patient group. Only when you have a plan to prevent adverse outcomes should you consider expanding this policy. I also find it curious that improved function is a criterion used to justify extending opioid therapy for up to 90 days following injury or surgery, but it's given no consideration when it comes to patients who have already received more than 90 days of opioid therapy. Many of these patients have benefited from long-term opioid therapy and risk decreased function and increased pain if their opioid doses are tapered. Given your endorsement of improved function as a criterion for successful opioid therapy, it seems to me that any opioid taper plan should contain a provision allowing the taper to be paused, stopped, and/or reversed if lower doses are associated with poorer function. In fact, I suspect that one reason you've experienced delays in tapering back and spine pain patients is that many of them have decreased function associated with their tapers, and therefore have slowed or stopped the taper. As the only organization in the country dedicated to promoting integrated pain management, AIPM applauds your efforts to improve access to a variety of non-pharmacologic pain treatments. And we believe that we need to have access to all the tools in our pain care toolbox if we're to be successful in relieving pain. However, while your policy would provide several new tools to people with chronic pain, it would also take away an important tool, and we don't believe that's the right way to proceed. Thank you.
Thank you. And Ginevra Lipton.
Can we let the patient that was gonna have to leave early go at some point?
Sure, do I have a name?
Who was it that had to leave early that needed to speak? They already,
I think Tim split.
Did that Tim ready to go?
Yeah, so it's okay.
Okay,
Proceed, please.
Am I using this right? Not yet.
Close to your mouth.
Is it on?
Yeah.
Okay.
Closer to your mouth.
Closer to my mouth even. Is that better? Okay.
Louder.
All right. I'm Karen Yergain. I'm from Prineville, so I traveled 4 hours to be here today. Thank you. I am a public health nurse of 30 years, and I'm a chronic pain patient of 8 years. And I've been watching what's happening in the public health world as well as the chronic pain world, and seen a lot of struggles around this issue. What I can say is that in Oregon, according to the Oregon Health Authority presentations at the Oregon Epidemiology Conference in the last couple of years, including this year, at first the presentations were saying that the diversion of prescribed opiates was causing the opioid epidemic. Evidence now is showing that's not the case. Evidence now is that just like when I was a kid and saw the movie The Cross and the Switchblade, which was about getting a young drug addict off of heroin going through major withdrawal, the problem hasn't changed. Street drugs, illicit drugs, are driving the opioid epidemic. What we are seeing in Oregon is decreased prescribing of opioids to chronic pain patients. What we're seeing in Oregon is not a shift of chronic pain patients moving to street drugs, but we are seeing an increase in suicides in Oregon. The presentation at OREPI said that that needs a little more study to understand why. the presentation several years ago said we expected that. On a personal note, I'm upright in here today because I am on chronic opioid therapy. Without that, I would not be employed. Without being employed, I lose my land, my house, my home, and my sled dog kennel. Opioids keep me functional enough that I can not only be a public servant, but that I can maintain my personal life in a decreased way, but I can. So I want to urge the committee to really look at the fact that chronic pain does need to be recognized. It is not short-term, it is the rest of my life. My dad died from cancer. They managed his pain so that his 7 weeks of high-intensity pain was down to very manageable for him. I have hopefully another 30 years at least to go managing this. Thank you for your time.
Can everyone hear me?
Yes.
Okay. I'm Ginevra Lipton. I'm an internal medicine physician. I practice in Portland, where I have an integrative clinic focusing on fibromyalgia. I also have fibromyalgia myself, so I speak as both a patient and a physician. I spoke before this group 4 years ago, I think it was about 4 years ago, when we were trying to get fibromyalgia above the line. And at that point, both me and Kim Jones were arguing about the need to cover things like acupuncture, massage, physical therapy, CBT. I think it's now fairly ironic that what it's taking to get this group to cover it is now the opiate epidemic, which is a problem. We all recognize that opiates are imperfect tools. They don't do a great job long term. We are having public health issues associated with it. If we bring fibromyalgia above the line, which we should have done years ago, and it's shameful that we haven't, we're the only state in the US that does not have Medicaid coverage for fibromyalgia. Now that we are bringing it, if we bring it above the line, we cannot do it in a punitive way. We cannot say, okay, yes, you have a real diagnosis, you have fibromyalgia, we will cover things like acupuncture and other evidence-based therapy, but we're also going to take away the tool that has been helping you. And this is a monster of our own creation. The reason why so many Medicaid patients with pain are on opiates is because that is what has been covered. That is the only thing. I battle every day to try and get different medications covered that are evidence-based, but that are not. I can't prescribe it for somebody on Medicaid because they have fibromyalgia and it's not above the line. I cannot get physical therapy coverage. I have been on the front lines battling to try and get my Medicaid patients with fibromyalgia and chronic pain better for a decade. And opiates are part of that. We cannot take away tools from our toolbox. We need to add, not take away.
Hell yeah.
Allan Chino and
Good morning. Thanks for having us here today. Dr. Allan Chino. I have no disclaimers regarding financial connections or otherwise. I'm in part-time private practice. I'm a clinical health psychologist. I've been a pain specialist for 28 years. I did the math recently. Past president of the American Academy of Clinical Health Psychology. Past director of the Oregon Psychological Association. Past member of the Oregon Pain Management Commission. I served 2 terms. So that's been my background. Co-authored with Corinne Davis, MD, of a book called Validate Your Pain. The nature of that book was basically instructing patients and professional groups some of the problems we kept encountering relative to our patients' histories. They had trouble being validated, essentially. Fibromyalgia was among the diagnoses that people really struggled with. And so I want to echo Kim Jones, Dr. Jones' discussion this morning and say we need to put fibromyalgia above the line. It's a true state of nature. People are suffering from it. We do have tools to help these people. So that's one of the things I wanted to mention. Briefly, I've been out of the policy loop for quite a while now, but became re-engaged with the opioid tapering issue and the proposed plan here. I want to say very strongly this should not go through. We will see a fundamental sea change in the pain management community relative to our capacity